Hi, my name is Janelle, and I'm a second year pharmacy student.
And I am Eric, a second year optometry student.
And we will be presenting on the patient Mrs. E. Her chief complaint is I'm taking too many medications. Can I stop taking my blood pressure medicine or diabetes medicine, even with my kidney problems? She is a 50-year-old woman who is counseled over the phone for MTM. She's diagnosed with multiple diseases like diabetes, diabetic nephropathy, and hypertension. But she's complaining about taking too many meds, so she's been exercising every day and cutting down on her portions in order to live a healthier lifestyle so that she wouldn't have to take so many medications. This is a list of her diseases. And for her past surgical history, she's had a removal of a cyst in her right breast and a bilateral tubal ligation in the 1990s. Her family history includes her mother having breast cancer and diabetes, her father having a stroke, hip surgery, heart attack, and also passed away at the age of 83 due to pneumonia. And her grandmother passed away due to pneumonia. Her social history includes that she's 50 years old, she's married, and she's a grandmother living with her family. She works as a secretary for the City and Council of San Francisco. She doesn't smoke or uses any tobacco, but she drinks occasionally about 5 cups of wine per month for the past 35 years. Her physical activity includes walking on a treadmill for 30 minutes, and she has lost 10 pounds within 2 months and has been eating less rice. She has allergies for niacin and simvastatin, in which she claims she gets rashes. And these are the lists of the medications that she is currently taking.
Okay, so on her review of systems, then constitutionally she reported weight loss and fatigue. Ears, nose, and throat, she has vision problems, hearing problems, and sensations of the room spinning and bleeding gums. Endocrinologically, like we stated, we're focusing on diabetes this time. Her respiratory, she does have coughing and shortness of breath. Heart-wise, cardiac, she has high blood pressure, heart palpitations, and she feels swelling in her legs. GI, she has heartburn and reflux, and stomach or intestinal ulcers. She often has burning with urination and difficulty controlling. Her joints often ache for her musculoskeletal system. She has no abnormal findings for neurology, hemes, lymph, and then, as we said, she has allergies to certain drugs which create rashes, and she often has depression, anxiety, and sleeping issues.
For a physical examination, when we interviewed her, she sounded pleasant and interactive. And from her vital signs from May 3rd, 2014, her weight is 165 pounds. Her height is 5'4", with a BMI of 28.3, which shows that she's no longer obese. And her blood pressure was 144/84, which is somewhat controlled, and her pulse was 82. In the fasting lipid panel, everything is within goal. And for the laboratory data, everything is normal except for the serum creatinine at 2.07, which is a little bit high, and the glomerular filtration rate, which is a little bit low, which goes along with her chronic kidney disease and diabetic nephropathy. The A1C is also a little bit high compared to what it was before. And in the urinalysis, it shows that there is proteinuria and some leukocyte esterase, which shows there might be an infection.
Okay, so as an optometrist then, my concern here today is going to be the progression of diabetes into diabetic retinopathy. So to diagnose that, to monitor that, I would be performing a dilated fundus exam and looking for signs, early signs of diabetic retinopathy using the ETDRS, or the Early Treatment of Diabetic Retinopathy Scale, looking for, as we'll say, microaneurysms, exudates, and hemes. So here is a breakup of quadrants as we grade the severity of non-proliferative diabetic retinopathy based on how many quadrants are being affected by those aforementioned symptoms.
And this is a list of medication-related problems. So the main problem that we'll be talking about is type 2 diabetes mellitus. So like we said earlier, Mrs. E is a 50-year-old Asian female with a chief complaint of taking too many meds. She's been diagnosed with type 2 diabetes for almost 10 years, in addition to moderate chronic kidney disease, which led to diabetic nephropathy. She has not had any hyperglycemic or hypoglycemic events and claims that her diabetes is well controlled with glipizide. She's been cutting down on her rice portions and walking on a treadmill every day for 30 minutes. She claims to have lost 10 pounds within the 2 months. And she used to take metformin and glipizide until her kidneys worsened, in which her doctor discontinued last year. She checks her blood glucose when she wakes up before she has breakfast, with her last reading of 148 milligrams per deciliter, and which is an improvement, she claims, which used to be 165 to 175 before she started exercising 30 minutes every day. She's been compliant with medications, but would like to know what are the consequences if she stops taking her diabetes medication. Like I said, the vital signs are still the same. There's a weight of 165, 5'4", 28.3, and 144. 84 is her blood pressure. And her A1C is high, 7.5%, which is an increase from her last A1C reading of 7.3% in November of 2013. But we do see improvement for her random glucose levels of 114, which was taken in May, but in April is 140, so you do see improvement. Her preprandial plasma glucose is 148, and her serum creatinine is 2.07. Glomerular filtration rate is 25, and her creatinine clearance is 28.1, which shows which goes along with her chronic kidney disease. So we assessed the patient, and we both decided that her A1C is not at goal. So she does have to continue taking the medications.
And especially with diabetic retinopathy, we are concerned if it approaches or exceeds 8%. So she's getting dangerously close to that.
And we'd also assess that her preprandial plasma glucose is not at goal, in which it should be between 70 to 130. And at the moment, her fundus doesn't reveal any diabetic retinopathy, but the patient does have diabetic nephropathy.
Okay, so the issue with type 2 diabetes is that patients are commonly asymptomatic and aren't aware that they have DM until a practitioner diagnoses them with a cofactor. So, the major thing we're looking at here is the length of time with this patient, as she's had it for about 10 years, which in the case of the eye gives her about a 50% chance of having diabetic retinopathy. So here we have an image of a healthy retina above, and then below we have an image of a non-proliferative diabetic retinopathy, which you can see that there are microaneurysms, dot and blot hemes, and exudates present here. The major thing we're worried about, because the patient wouldn't be aware if they have non-proliferative, but once it becomes proliferative, the only difference being, of course, the progression of neovascularization in the retina, then they can start having symptoms. On the lower right, you can see a fluorescein angiography of macular edema from diabetic retinopathy, which would cause distortions in their vision. And then the lower left, that eye you see has a neovascularization of the iris, which can close off the drainage system of the eye and create glaucoma.
Our plan and a goal of therapy is to resolve her chief complaint, which is to decrease the pill burden and increase her quality of life. We also want to decrease her A1C, random glucose, and preprandial glucose levels. We also want to decrease adverse effects of her medications, preventing hypoglycemia, and prevent further complications like diabetic retinopathy and the progression of her diabetic nephropathy. So what we want to do pharmacologically, because she wants to decrease the number of meds she wants to take, we would want to switch her glipizide 10 milligrams tablet, in which she takes twice a day, to glipizide extended release 5 milligrams tablet, in which she'd only have to take once daily. And this would decrease her pill burden.
Okay, so non-pharmacologically speaking, we're going to want to encourage her to continue that exercise and her current diet, limiting her simple carbs to around 130 grams a day and increasing her high fiber to about 25 to 30 grams a day. She's already drinking a moderate amount, which is good, and we want her to drink 64 ounces of water a day at least.
For monitoring parameters, we'd want to do her A1C, in which it has to be below 7%, her preprandial plasma glucose, which should be between 70 and 130, her serum creatinine, so we keep a lookout for her kidneys, proteinuria, so that we can look out for her kidneys as well, and a fundus exam for the eyes for diabetic retinopathy, which we'll be looking for microaneurysm, hemes, and exudate. For efficacy, we want to see a reduction in A1C, random glucose, and preprandial. And toxicity for the glipizide, we'd get hypoglycemia, weight gain, and less common rash, hemolytic anemia, GI upset, and cholestasis, and also photosensitivity. For follow-up, we want to check A1C and fasting blood glucose every 3 to 6 months, check serum creatinine and albumin protein levels in the urine for her diabetic nephropathy, an annual dilated eye exam to check for diabetic retinopathy.
Okay, so again, we're going to educate our patient on the importance of an annual eye exam and the possible complications of her conditions, in other words, the progression into diabetic retinopathy. Again, keeping on her with the exercise, the diet, the alcohol, and drinking, perhaps even including telling her to keep a food journal in order to keep track accurately of what she eats. So I think the importance that can be seen from this project is the simple fact that a lot of systemic conditions can have ocular findings, but as an optometrist, I have to work with other professions to really attack these problems. Pharmaceutically, then the treatments of multiple systemic conditions have various drug-drug interactions, so we always want to keep on track with those. And so in any of these instances, the cooperation of healthcare providers is important and required for a competent and complete approach to patient health. And here's a list of our references.